talk about health equity and ethics and reality of MCED implementation. One group has already formed and started using an implementation model and presented their research at ASCO this year. Would you like to talk a little bit more about this presentation?
I think you're the best person to speak about this, given that you are in the primary care space and you have firsthand experience developing such a program. Quite a good one.
Thank you, Dr. Schram. I appreciate that. This Agrawal study about Mercy Health System and their multi-state implementation took a look at centralizing MCED testing implementation within a multi-state healthcare system. So they launched in January of 2023. There are almost 4,000 referrals, led to 925 MCED tests being ordered. And what this poster showed us was that their median time from a cancer signal test result to the patient notification was 22.8 hours. And to initial diagnostic evaluation was 3.1 days. And to a cancer diagnosis was 8.7 days. I only dream of such amazing numbers in regards to shortness of time. But I think what this presentation showed us was the ability, with careful thought, prior to rolling out something new like multi-cancer early detection, and focusing on central navigation as well as nurse navigation, and having pathways already created before implementing this kind of testing, we're able to do what's right by the patients and not increase their anxiety, but get them the testing and the workup that they needed in a very short amount of time.
That's remarkable. A week to diagnosis from initial screen is enviable even in traditional screening methodologies.
I do know that there were a few presentations about health equity and as it relates to the use of MCEDs and the implementation into general practice. Can you shed some light on those for our learners?
Sure. The first one was a publication at ASCO in Chicago in June, looking at health equity challenges involving testing and evaluation and implementation of MCEDs. This was a description of the plan of the MCED Consortium, which is a public-private collaboration in the US and the UK, dedicated to reducing the burden of cancer, but trying to figure out how we can best use these technologies equitably and at a responsible cost. The challenge is that these tests and any new technology generally disproportionately increases access to the insured and high socioeconomic groups before they make it to people who are underinsured or uninsured. And so how do we best roll these out to improve access to all? This and other health equity MCED challenges were discussed also by Leonard Fleck in another publication, abstract only at ASCO. The argument was that it would cost Medicare billions to roll out MCED type testing and all the downstream costs from following up on this testing, and that there was really no way to account for how to pay for this, even if MCEDs were reduced in price by 40% over the next 4 years. There's valid argument about what the cost of these tests might be. The question I think somebody needs to pose is, what's the cost of not doing this? What's the cost of not having screening tests? That would be a good kind of debate to have.
Thank you, Dr. Schram. And as we know, with these kind of new cancer screenings or new tests, it's difficult to project where the cost savings will come from and the outcomes, especially as these MCED tests are finding cancers that we're not used to treating or taking care of, at an earlier stage. So it's going to be interesting to see where this actually falls. And is the cost of this kind of testing and diagnostic going to be offset or balanced by the cost savings associated with catching a cancer at an early stage? And we know that's a lot less of a cost to our health system than, catching cancer at a later stage and the burden or the financial burden that goes along with that. So maybe there would be an even ground from that standpoint.
Perfectly said, yes.